Hello friends, let us learn about a new topic today. This topic is given in stomach in Harrison. So I'm just dealing it just after the stomach so that I don't forget doing this topic. So that is zollinger-ellison syndrome. So what does this zollinger-ellison syndrome suggest? So zollinger-ellison syndrome is the presence of gastrinoma. Due to gastrinoma, which is a non-beta cell endocrine tumor, there is increased gastrin. This causes increased HCl secretion, which leads to ulceration. Right, so this is what is generally an outview of what happens in Zollinger-Ellison syndrome. So let us learn about the pathogenesis of Zollinger-Ellison syndrome. So pathogenesis. So here there is a tumor which is in gastrinoma. So this gastrinoma, as I have said, there is increased gastrin secretion, which is called as hypercalcemia. So this gastrin goes and it stimulates gastrin receptors in parietal cells, and also it activates histamine. First it activates enterochromaffin like cells, this activation leads to production of histamine, and these gastrin receptors which are activated, so this leads to increased HCl production. This is what generally happens. As days passed by, that is whenever there is long-standing hypergastrinemia, in long-standing hypergastrinemia, this will lead to increased parietal cell mass also. Right? So, whenever there is increased HCl, after that what happens, you will see in the clinical manifestations. So, let us learn about the tumor distribution. Where is the tumor seen right now? The tumor is seen, 80% of the tumors are seen in a triangle which is called as hypothetical gastrinoma triangle. There is a triangle which is called as hypothetical gastrinoma triangle. Over here, the tumor distribution is mostly seen. So what is hypothetical gastrinoma triangle? So this occurs majorly in, this is the duodenum, right? And there is the body of the pancreas is seen here, right? And then you will have two things which are cystic duct with gallbladder and right and left hepatic duct, common hepatic duct and common bile duct opening into the duodenum. Second part of the duodenum. So now here there is a hypothetical gastrinoma triangle where it is bounded by cystic duct and common bile duct superiorly here, and the junction of second and third portions of the duodenum inferiorly here, and medially you will have the medial border of pancreas, right? So this is what is called as gastrinoma triangle. So you will have cystic duct and common bile duct superiorly, and you will have body and neck of pancreas medially, and then you will have the duodenum, that is second and third portions inferiorly. So this small triangle, generally it is a small triangle because of some unequal proportions I have drawn that had resulted in different proportions. So this is the triangle. Over in that triangle there are many tumors. The tumors are common. I know the proportions of this triangle went completely wrong, so I'll draw this again. That will bring back the proportions in a better way. So I'll draw it down here, right? So this is the stomach, right? So this is the duodenum. Into the second part you will have the right and left hepatic duct, common hepatic duct, and when cystic duct joins, that is called as common bile duct, and this comes and joins in the second part of the duodenum. And then you will have the head and neck of the pancreas. So at the junction of head and neck of the pancreas is the medial border. So now I'll get a triangle, just see. So this is the cystic duct and this, so this is the superior border, and this is the second part of duodenum and third part of duodenum. This is the inferior border and this is the medial border. So you can see a triangle here which is formed. So this is the triangle which is formed. Okay. So this is the inferior, superior, and this is the medial border. Okay. So this is the triangle which we get. So that is called as gastrinoma triangle. Hypothetical gastrinoma triangle. Over this triangle, there are many gastrin, tumors. So there can be so here in this triangle there is duodenum and there is pancreas. Majorly these two are the tumors which are seen in zollinger-ellison syndrome. If there is duodenal tumors, these duodenal tumors are smaller and slow growing, whereas pancreatic tumors can also occur, that is gastrinomas. These pancreatic tumors are fast growing. They grow really faster. And then there are also some extra pancreatic sites where this tumor is seen. So those extra pancreatic sites include stomach, bone, ovaries, and liver, and heart, and lymph nodes. So stomach, bone, ovaries, liver, heart, lymph nodes. So these are the extra pancreatic sites where you can see this tumor. Histologically, they are well differentiated cells and they produce gastrin and they also have certain markers. Those markers include number 1, chromogranin, and then neuron specific enolase. Right? So what are the clinical features which are seen in gastrinomas? The major clinical features of gastrinomas is due to increased HCl production. So whenever there is increased HCl production, this will predispose to peptic ulcers. So this is the most common manifestation. So in peptic ulcers, even these peptic ulcers are seen in unusual locations, which are in locations which are not common. So like second part of duodenum. So that may be seen at unusual locations like second part of duodenum. That is 1 or beyond. So they are seen after, from here to the hole, they can be seen anywhere. And you can see ulcers which are refractory to therapy. You have given therapy but still you get ulcers again because of increased gastric acid production, that is because of increased gastrin. That is, ulcers may recur after surgery. If any ulcer recurs after surgery, always consider this gastrinoma or Zollinger-ellison syndrome. And then complicated ulcers. Right? So this is the major manifestations. Along with ulcers, there is one more manifestation, which is diarrhea. Diarrhea is the most common manifestation in these patients. So why is there diarrhea? So here the major reason for diarrhea is there is increased HCl. So this increased HCl will inhibit or inactivate pancreatic enzymes. That is 1, and this will damage the epithelial surface. Excuse me. It will inactivate the pancreatic enzyme, or it can damage the epithelial surface. That is intestinal epithelial surface, not just the gastric epithelial surface leading to ulcers, but it can also damage the intestinal epithelial surface. So epithelial surface, whenever there is damage to epithelial surface, this leads to maldigestion and also malabsorption. Right? So this is what generally happens. Then why is there a diarrhea? This is because this gastrin will stimulate enterocytes within the intestine. So in the intestine you have enterocytes. So this will stimulate these enterocytes in the intestine, and these enterocytes secrete all the fluid into the lumen, leading to secretory diarrhea. So this is one of the manifestation of Zollinger-Ellison syndrome, where you see diarrhea. These gastrinomas can also occur in 20% of the patients. These are associated with MEN syndrome, MEN1 syndrome. Right? So what is MEN1 syndrome? So MEN1 syndrome, it is an autosomal dominant disorder in which there are tumors at 3 sites, that is parathyroid glands, and then at parathyroid glands, and then at pancreas, and then at the pituitary gland. So there are at 3 sites, at parathyroid, at pancreas, and at the pituitary gland. So there are tumors at these 3 sites, and this is majorly due to the genetic defect on in MEN1, that is genetic defect in long arm of chromosome 11, that is 11q11 q13 areas. Okay, so in here, in this patient, there is pituitary gland tumor, which leads to hyperparathyroidism and hypercalcemia. So here pituitary gland tumor leads to hyperparathyroidism, leading to hypercalcemia, there is increased calcium. Right? So this hypercalcemia will decrease gastrin, and thus decreased gastric acid output. Hypercalcemia, this hypercalcemia increases gastrin and also increases gastric acid output. So this is one thing, hyperparathyroidism causes hypercalcemia. This also increases gastrin production, leading to gastric acid output. There is increased HCl again. This will aggravate the peptic ulcer disease. So for this, if you do parathyroidectomy, what happens? If you do parathyroidectomy, then there is decreased calcium. So this leads to decreased gastrin, and there is decreased gastric acid output, thus resolving the ulcers. Okay, so this is one of the treatment option which is available. So in MEN1 syndrome, there is also a high risk of carcinoid syndrome. So what is the diagnosis? How do you diagnose this zollinger-ellison syndrome? Number 1, the best diagnosis is through knowing fasting gastrin level in the serum, fasting serum gastrin level. So what are the indications for doing this fasting serum gastrin level? So this is done, number 1, in the stomach or in the duodenum if there are many ulcers. Number 1, multiple ulcers. That is number 1. Number 2, ulcers in unusual location, which are not in normal location. Whenever there are ulcers in unusual location, then you do this. And whenever there is ulcers resistant to therapy, refractory to therapy. And 4th, post-operative recurrence of ulcers. Okay, all these are related to ulcers. And then so this can also occur whenever there is diarrhea, that is unexplained diarrhea or steatorrhea because of pancreatic enzyme inactivation. Unexplained diarrhea or steatorrhea, even when this is there, you should look for fasting serum gastrin levels. And whenever there is hyperchlorhydria, because there is increased HCl, so there may be hyperchlorhydria. Even then you will have to look for serum gastrin levels, fasting serum gastrin levels. And then if you have the family history of peptic ulcer disease, or if you have a family history of pancreatic or pituitary or parathyroid disease. And also the eighth one is whenever there are many prominent gastric or duodenal folds. Prominent gastric or duodenal folds. So in all these conditions, you generally look for fasting serum gastrin level, and also whenever there is increased calcium levels. So these are the conditions where you look for serum gastrin level. So these are the indications. And then what is the serum gastrin level? Normally the serum fasting gastrin level is less than 150 picogram per ml. So in gastrinomas, this will be more than 150 to 200 picogram per ml. So in some conditions, even though when there is no Zollinger-Ellison syndrome, there may be increased fasting serum gastrin levels. So it is not a perfect test for detecting Zollinger-Ellison syndrome. Once this is more, then do next assess acid secretion. Then assess acid secretion. So if there is decreased acid output can be done, or normal or increased gastric output can be observed. Okay, when the basal acid output So before knowing into it, before going into the assessing the acid secretion, because there is no value if you don't know the conditions where serum gastrin level is high without a gastrinoma. Conditions where serum gastrin level is high. So number 1, whenever there is gastric hypo or achlorhydria, this will activate G cells, leading to increased gastrin production. The second type is G cell hyperplasia. This will again produce increased gastrin. Then the third one is gastric outlet obstruction, and also small bowel obstruction, right? Small bowel obstruction, or in renal insufficiency. In all these conditions, there is increased serum gastrin levels. So in order to change it, you will have to do the second investigation, which is assessing the acid secretion. So once you have assessed acid secretion, you might have two outcomes. One is decreased acid output, and the other is normal or elevated acid output. If it is decreased acid output, you can easily exclude zollinger-ellison syndrome, because in zollinger-ellison syndrome there is always an increased acid. So then if there is increased acid output, then you will have to do the other tests. So now you can do you will do the next test, which is measuring basal acid output and also maximal acid output and knowing the ratio of both. If this basal acid output and maximal acid output is less than 0.6, then always exclude zollinger-ellison syndrome. If this is more than 0.6, then it suggests zollinger-ellison syndrome. Then how do you evaluate this gastric acid? So right now we can evaluate it by endoscopic method of measuring gastric output is available. It is developed, right? So now this is the second one, assessing basal acid output. And now you can do some of the other tests to differentiate hypercalcemia and other tests and other differential diagnosis. So that is by Gastrin provocative tests. In Gastrin provocative tests, these are majorly to differentiate between the causes of hypercalcemia. So there are two studies which can be done. Number one is secretion stimulation test. Here you will inject secretin, and then you will wait for 15 minutes and then measure gastrin levels. If this gastrin level is more than 120 picograms, then it is zollinger-ellison syndrome. Right? Some things can also give false positive secretin test. The false positive secretin test is seen if if the person uses PPI, then there is PPI induced hypo or achlorhydria. So this also increases the gastrin level, right? So everyone should stop PPIs at least 1 week before testing. And then the second gastric provocation test is calcium infusion study. It is less specific and not much done because of adverse effects. So not done. So here in secretin stimulation test, it has 90% sensitivity and specificity. So it is the best investigation right now. Okay, after doing the measuring the fasting gastrin levels and then acid output test, assessment. So these are the investigations that you do generally. And then for knowing that there is zollinger-ellison syndrome, for knowing the tumor, you'll have to localize the tumor. So tumor is majorly localized by a scan, which is endoscopic ultrasound. This has a high resolution. and by this we can even detect or exclude even the small neoplasms in the pancreas, and it also helps in assessing the lymph nodes, and it assesses the depth of tumor and lymph nodal status. And there is one more test where we give somatostatin analog, which is 111 indium pentriotide. When you give this, we can localize the gastrinomas, because these will stain the gastrinoma. Right? We can also do ultrasound and CT scan or MRI. Or there is a scan which is octreoscan. This is octreoscan. This is the thing which is called as octreoscan. We have already mentioned it. So these are for metastatic diseases. So now what is the treatment of Zollinger-Ellison syndrome? The first treatment is PPI, proton pump inhibitor. In the proton pump inhibitor, we can give omeprazole or lansoprazole or rabiprazole or esomeprazole. All these are given in 60 mg in divided doses for 24 hours. So these doses are adjusted. So the aim is to achieve the basal acid output to be less than 10 milliequivalent per hour. Okay, so this is the main, we have to achieve this. If we have to do surgery, or they should, for surgery, and they should be less than 5 milli equivalents per hour if previously surgery is done. So for adjuvant therapy, octreotide can be used. Octreotide is a somatostatin analog. This will inhibit gastrin release and thus inhibits gastric acid secretion, that is HCl secretion. Right? So the ultimate thing that is important is doing a surgery. We'll have to do a surgery for it. So here the major treatment option is surgery. So in surgery you will excise the tumor, excise the gastrinoma. Right? So this is about the Zollinger-Ellison syndrome. So I would like to just draw this triangle again, because I'm not I'm not justified about this triangle. So I looked up and then I found out that all these are junctions of, you'll have to take these as points and you'll have to draw a triangle. So we'll do it right now. So in this there are three major boundaries. So I'll draw it with this one. So first junction is junction of cystic duct and common bile duct. So this is the junction of cystic duct and common bile duct with black. Junction of cystic duct and common bile duct is this one. And junction of body, this is the body and neck of the pancreas. So here. And junction of second and third third of duodenum. So this is second, this is third. So this is the thing. So this is the gastrin triangle. Right? So this this is hypothetical gastrinoma triangle, and there is one more name for this hypothetical gastrinoma triangle, which is called as Pesaro's triangle. Pesaro triangle. So this is the major thing which is important in gastrinomas. Thank you guys. Okay, 1 minute. The last thing. That is, what do you do? What surgeries do you do? I said it's surgery, excision of gastrinoma. But how can you excise the gastrinoma? Right? You should know even that. So, with this Pesaro's triangle, we can say that, I'll write it in my next page so that I don't need to shift the page in the middle of the diagrams. So, we have said that this is the duodenum. This is the pancreas, and then the stomach will be like this. The stomach will be like this, it won't be like this. So, and then you will have the ducts, that is the duct, cystic duct, right and left hepatic duct, common hepatic duct combining with the cystic duct, forming common bile duct, and that drains in the second part of duodenum. Right? So, if you see here, you have, this is the junction between the cystic and the common bile duct, junction between the head and neck of the pancreas, and junction between the second and third parts of duodenum. Then you have drawn a triangle. So, this triangle, in this triangle, this is called as hypothetical gastrinoma triangle. So, in this triangle, there are two structures, if you see, that is duodenum and pancreas. If tumor is in pancreas, then you can do, based on the site, you can do two types of resection. One is, if this is the head and then pancreas, and this is the one. Okay, so you will have to do a subtotal pancreatectomy or distal pancreatectomy. Distal pancreatectomy. So you will have to do either subtotal or distal pancreatectomy. How do you do, and all the other things we will learn it in our pancreas chapter, so that will be better than doing it now, right? So this is what you can do. And if duodenum is involved, if tumor is in duodenum, that is duodenum is involved, then you can do pancreatico-duodenectomy. If duodenum and pancreas are involved, pancreatico-duodenectomy. Okay, so these can be done, and you can even do enucleation of tumors. So these are the treatment options which are available for gastrinomas and Zollinger-Ellison syndrome. Thank you guys for watching my lecture. If you feel something is inadequate in this lecture, please comment it in the comment section. If you feel I should add something, then comment it in the comment section. Thank you for watching my lectures. Thank you.